Bueno, vamos a continuar.
So let's move on then with these very interesting presentations.
Está a cargo de, bueno, los coordinadores son las
The
doctoras
coordinators are Dr. Gabriela Pichichero and Dr. Juliana Martinez from CEN.
Esta conferencia
This conference is about hereditary EB, what I have learned the most, by Dr. Vicente from Villa, Spain.
No sé si están ahí.
Are you there?
Si me escuchan, porque no estoy escuchando.
Se escucha,
Estoy
sí.
teniendo muy,
se escucha,
muy buen
se escucha
retorno.
Sí,
perfecto.
doctora Vicente, se escucha.
Yes, we can hear you, Dr. Vicente.
Hola.
Me corresponde presentar a la doctora.
So I would like to present Dr. Asuncion Vicente Villa. It's a pleasure for us to have you with us today. She will be sharing her experience. She's a pediatric dermatologist, chief of the EB department at the San Juan de Dios Hospital in Barcelona, Spain. And it will be a pleasure to listen to Dr. Vicente. The cases that have what the lessons learned from EB. Over to you.
A ver si se ve la presentación. Buenos días desde Buenos
Good
Aires.
morning for Buenos Aires. Good evening here in Spain. It's already night. First of all, I would like to congratulate the organizers of this meeting. It's a very successful meeting, a lot of people participating, a lot of people connected. I would like to thank you all for the invitation, especially my friend Gabriela Mansur, for this opportunity. We would all love to be in Buenos Aires, but well, that's the situation. I hope this ends soon to meet again. Well, there are so many speakers, and so I have decided to talk about simple, well, important cases that have taught me a lot in daily practice. Well, I would like to tell you that these are cases from the EB department in our hospital, the Hospital San Juan de Dios in Barcelona. Well, there are classifications. The hospital is in the south of Barcelona. This is an old photo, and this is the new photo. Well, to work with complex cases is not easy. We have to coordinate, a lot of professionals participating. We need coordination. I'm the coordinator, then we have a basic team, the pediatricians, dermatologists, the pathologists, and the geneticians, and then an MDT, including specialists and surgical specialists. Of course, we would not take care of our patients without the nurses, without clerical people and social workers. Many of these cases, well, practically all these specialists have participated, have been involved in the management, and this is in alphabetical order, so as not to offend anybody. In our children's hospital, these children were there transferred to the clinic hospital in Barcelona because we worked jointly. We do children conditions and then they are referred to the clinic. It's a referral center for EB nationwide. And as a specialist in EB, I insist we follow the guidelines. As you can see in the guidelines, in the cases, we use the 2008 guidelines, but then we will have to move to the 2020 guidelines published last year, published in the British Journal. Now, what about the classification? What is the diagnostic model? That's what I'm going to present. We base our diagnosis on the clinic. The second test is antigenic map of the basal membrane, and then molecular genetics. The biopsy is processed in the pathology department, and molecular genetics for some years now used to be practiced in Madrid. Now we do that in our hospital. We have a pediatric institute for rare diseases. It's IPER, that's the acronym, providing clinical and lab care for these rare diseases. And then we make a diagnosis. We do biopsy, the separation, the type, inheritance, what protein is mutated, and which is the gene and what mutation is present. This seems to be very simple, but what about these classifications you see here in the slide? So we learn new diagnostic, we acquire diagnostic resources, including new entities, and then we offer new classifications. As you can see, this is not so easy. And so I have chosen the cases that have taught me the most. First one is a 1-month-old boy, is the first son, a non-consanguineous couple, a normal pregnancy, and a vaginal term baby. At the age of 10 days old, he had skin lesions involving hands and feet. Here you can see the ampoules with clear content involving the fingers, and also the patient has this presentation in the ankle and feet. The child is 3 months old. These lesions are not many, residual erythema. The patient has no lesions in the mucosa. The mother is healthy. The great-grandmother on this father's side had skin lesions as a child, and of course she didn't know about the diagnosis. The parents never come to any visits. This is the pedigree, the great-grandmother, the father, case 1, the case proband. And so this is autosomal dominant inheritance. What about the guys? Skin fragility, ampoules, dominant autosomic inheritance. The patient had ampoules in the neonatal period and of course in childhood. Therefore, this is hereditary EB, dominant autosomal inheritance with a good prognosis. We perform a skin biopsy and antigen mapping of the baseline membrane, inducing an ampoule in the skin, in the apparently healthy skin. And we obtained DNA. This is the immunofluorescence. You can see the expression on all the proteins under study. And if we do a scheme, the separation, and all of them deposited in the ampoules. So diagnosis was simple. It was simplex EB, located in the hands and feet, and good prognosis. This is the classification of 2008. Was diagnosed as EBS. That used to be known as Weber cocaine, and today is called localized simplex EB. The patient was referred to this department, and he was treated as an outpatient. But 3 months later, in my private office, I saw a 3-month-old baby that was a cousin of this baby. It was the first son of non-consanguineous parents with normal pregnancy. Also had ampoules from the first day of life in both hands and feet. Here you can see this is a second patient with this blistering, with erosions and crusts. We performed a biopsy showing some changes. So we made a diagnosis of localized EBS. We included the pedigree. Here, this is the complete pedigree. This patient was accompanied by the family, the mother, and the grandmother, who had also the same disease. This grandmother and mother had no ampoules, no scars, no mucosa lesions, and no manifestations in other organs. But what do they have? They have 2 skin manifestations that led to diagnosis. This is the mother, a young mother. Since the age of 3, she has pigmentation, this disruption, affecting practically all the tegumentum, the face, the limbs, with this type of pigmentation with hypopigmented areas, altering with hyperpigmented areas. This family, well, they had been told that the stains were due to sun exposure. They had fair skin and they had this type of stains, but this was not important. Again, you see here the limbs, you see the hypopigmentation and hyperpigmentation the patient has had since the age of 3. And again, she had the mother and the grandmother since the teenage year had warts, keratotic lesions in the palms and the hand and the soles of the feet. Here you can see them very well as you follow the arrow. The mother, and this is the grandmother. They also had this in the soles of their feet. We did a biopsy, keratotic. It showed a hyperplastic, thick epidermis without changes. So he had orthokeratosis. And we had 6 guides and poles denoting skin fragility. The mother and the grandmother did not have this. There was pigmentation disturbance and puntata, keratodermia puntata. So the diagnosis was, well, this diagnosis was ruled out. And in the 2008 classification, we moved to the EBS pigmentation type of the disease. So what is this about? In the normal classification, it would be included here with autosomal dominant pattern because of keratin 5 mutation. Now, what happened to these children? The child, case number 1, at the age of 2, started pigmentation. He had skin fragility. You see here hyperpigmentation in the back of the hand, but still he has skin fragility with these little erosions. The second patient, the cousin at the age of 2, really had hyperpigmentation, more significant hyperpigmentation or motile hyperpigmentation in the arms, and also he had skin fragility. When we diagnosed the 2 patients, we got the molecular genetic tests. In our country, that used to be very expensive. We used to do that in Scotland, and it took some time to get the results. All the patients, all the relatives had an heterozygosis mutation in the KRT5 gene, the missense mutation, Pro20. Well, this is a very rare type of disease, of the simplex form of the disease, and sporadic cases have been reported. In 2013, we published our experience with 1 case of the Neo Jesus Hospital, and we did a review of the literature. In 23, there were only 15 families with these sporadic cases and 8 cases. Now there are 5 cases more. The clinical presentation changes with age, is characterized by skin fragility, pigmentation, and hyperkeratotic lesions. Keratodermia puntata is the word. It's located in hands and feet. It occurs in first years of life. There will not be any scars, and apparently it will cure. Adult patients practically do not have any sign of the disease. However, this motile pigmentation appears after the age of 2, increases with age. It may ameliorate, but never disappears, and it's alternating with hypopigmentation. It involves the limbs, the abdomen, can be generalized, and is not preceded by ampoules. So in some cases, it always spares the trunk. This is funny because the last case reported in the literature from Brazil also calls our attention. Patients present this hypopigmentation in legs and arms, but not in the abdomen. Hyperkeratotic lesions are in the palmoplantar, but also there can be multiple lesions, these wart presentations in the back of the hand.
This persists throughout life. We also have problems on the nails of dystrophy, photosensitivity, telangiectasias, and other things. This is due to a mutation of keratin 5. Also, there are cases of keratin 14 or 1 case of exophyllin 5. In this particular case, the mutation is homozygote. The most frequent is CAR-T5 mutation. It does not involve the mucosa or extracutaneous areas. And these patients have taught me, well, the importance of the clinical aspect of the diagnosis, having to deal with the lack of complex diagnostic techniques that we did not have at that time. It's very important to have a correct clinical history initially, because it would lead us to an early diagnosis. We had the diagnosis even before we received the results from the genetic study. This patient had almost no cutaneous fragility, a very, very mild keratodermia. This is a problem of pigmentation, mostly. You can see the keratotic lesions. And the second case, now 17 years old, with minimum fragility. He has a band-aid on the ankle, but there is a problem with pigmentation that's getting worse. It's very, very dramatic, and you can see it even on the extremities, not on the trunk, and you can see the images. And this is a severe aesthetic problem. And there's multiple keratotic lesions that have increased in the dorsum of the feet. And this child had a brother 5 years younger, but with the same pigmentation disorder. You can see on the ankles these keratotic lesions and the pigmentation disorder. They are ashamed because of this, so it affects their quality of life. So what have I learned? The cutaneous fragility is characteristic of this disease, but the problem mainly is the aesthetic problem due to the pigmentation disorder, and this affects their quality of life. The second case that I wanted to share was many years ago. This was in summer, August in Barcelona. You only have people working there. Everybody else is on holiday because it's the height of summer. This was a newly born girl, first child, healthy parents, normal delivery and pregnancy, and she had erosions and blisters in 30% of the skin. She was born in a private hospital. She had biopsies done and sent to immunofluorescence and electronic microscopic evaluation, but she was sent to us because they have no diagnosis, and she had a general deterioration of her status. This was at 7 days of age. So you can see a high percentage of the surface of the skin was affected, erosion, very, very severe. The skin was truly very affected. We have vesicles and blisters. The nails were normal, but you can see a deglobing of the hands, milium cysts. And the patient in the UTI had generalized cutaneous lesions with progressive and fast worsening. The status was very severe. This is at 10 days of age. So she was worsening very fast. You can see the lesions on the face, in the hands and the feet. Nikolsky was positive. The skin was coming off in sheets. The blisters involving the oral mucosa, most of the oral mucosa, milium cysts, and she was hoarse with crying. So we have 3 cutaneous signs: the blisters, the erosions, very severe, milium cysts, and she is hoarse. So the clinical orientation was EAG, severe ERG, what we call Hertlitz, junctional EB. We thought that was our first diagnosis. There were other possibilities, but that was our thought at the moment. And based on that specific classification, we asked for antigenic mapping of the membrane. At that point, what happened with the classification of 2008? Well, optic microscopy, what happened with that? And what happens specifically in EB? There is a lack of diagnostic value of optic microscopy. There are not a lot of descriptions of EA staining, but we perform the biopsy and we process it. And you see the blister, intraepidermic, supravasal, and there was an area on the granulosa layer, the spinosa layer, and the granulosa was almost intact, but there was like a loosening or separation of the cells, very characteristic, as you can see here. It was acanthosis, very easily seen, even if you don't have a lot of knowledge on the of histopathology. So we have the diagnosis of pentigo vulgar, neonatal pentigo vulgar, and we know that these are a very rare aspect of acanthosis, and we thought that the fragility of the skin was very severe, and this emphasized our diagnosis. We know that this is a very infrequent pathology. We have generalized blisters and erosions. It affects the mucosa, and the mother had pentigo vulgar as well. So the prognosis is that it would improve in 3 weeks. Histopathology is separation, supravasal separation with acanthosis in the spinosa strata or layer. We have direct immunofluorescence with intercellular deposits of IgG and C3 in the epidermis with antibodies from the mother. So that was a possible diagnosis. The foliaceous pentigo as well was not seen in our case. The mother had no pathology. The mucosa is not affected in this pathology. So the histopathology was not what we found specifically in this case. So we have intercellular deposits of IgG and IC. So the histopathology and the clinics were not this pathology. So we remain in our initial diagnosis. The SSS neonatal syndrome is with erythema and high mortality, and this was not what we saw in our patient. The protein was this desmoglein 1, and we searched for Staphylococcus aureus in our patient, but there was all negative results. So neither the clinic nor the laboratory suggested this diagnosis, but there was acantholytic epidermolysis, and this was described in 2005, the lethal acantholytic AB with recessive heredity. This is from desmoplakin, is a cytoplasmatic protein participating in the formation of desmosomes, and it is essential for the integrity of blood vessels. This had been described in 2005, as we said before, and this is very similar to what we see in our patient, very severe, rapid erosions up to 90%. Nikolsky was positive. The skin was coming off in long sheets. The hands and feet were degloving, and it involves the mucosa, both oral, gastrointestinal, urinary, and others. At the level of histology, we have supravasal separation with spongiosis and acantholysis for vulgar pentigo. The separation intracellularly is between the desmosomes and the cytoskeleton, and the desmosomes and hemidesmosomes are normal. In the immunofluorescence study, studying desmoplakin 1 and 2, we see intercellular dye. that cannot be seen in healthy skin. So we also need to remember that this is a very serious disease. They died within the first few days. So those were the two options for the diagnosis. As we evaluated the patient both clinically and through the laboratory, the patient was in a very severe situation in the UTI. The cutaneous barrier was lost, there was sepsis, and there was metabolic acidosis, hyponatremia, hypopotasemia, hypoproteinemia, anemia, urinary infection. The treatment was very painful, and she was 2 months of age. So she survived two months, but we needed a lot of support. And this patient was in a very poor condition. We did direct immunofluorescence to improve our diagnosis. We also biopsied the mother indirectly with immunofluorescence. There was negative results for intercellular antibodies, and the desmoid 1 and 3 antibodies was negative for the mother. So we discarded the first diagnosis and we had the second diagnosis. For complete and confirmation diagnosis, we did an antigenic mapping of the basal membrane, but we only have these proteins, integrin, laminin, and collagen. We see the immunofluorescence, and this was normal. And the blisters happened in the basal keratinocytes. So it was a simple EB, and this again will ensure our second diagnosis. This is at 18 days of life. You see that this was worsening. The skin was mostly affected in 100%. You can see the epidermis was coming loose in sheets. And we have erythematous areas without any covering tissue, but we still could see some blisters. So our patient, in fact, was lethal, like acantholytic EB, 90% of erosions, sheaths coming off the skin, the deglobing of the hands, affection, the mucosa was affected, alopecia, and this hoarseness. There was one difference whatsoever. We could see vesicles and blisters, milium cysts. The nails were normal. She had no teeth that we could evaluate, and the patient had not died. She was still alive, different from what we would seen in the lethal acantholysis EB. So for confirmation, we needed to dye the altered desmoplakin that we did not have at the moment. We asked for Dr. Honkman to help us, and he determined the study for desmoplakin, placoglobulin, pectin, and others. So this diagnosis that we thought was great and brilliant was in fact not correct. But we have processed samples for electron microscopy. The desmosomes were normal, but the basal keratocytes, we saw a clumping of the filaments. So our patient had a simple IB, or what we call simple severe. The patient improved, multiple million cysts. You can see the blisters were less plentiful as time went on. We have a bit of improvement, and the mucosa as well was better. The involvement of the nails had increased their curvature, and we have keratosis and periangle scaling. She lost all her nails, and when the patient had improved so much, we finally received the result of the genetic test, and we saw a mutation in N123S of the CART14 gene. This epidermolysis is autosomic dominant with mutations in CAR-T5 and 14. And the most severe forms go hand in hand with hoarseness. This was called herpetiform blisters. It has milium, anatrophic scarring, and onchodystrophia and loss of nails. And in adulthood, they could have a plantopalmar affectation involvement. Anemia, the growth delay, the oral mucosa, digestive and respiratory mucosa has improved with age. What can we find in the literature? And that is why I wanted to share this severe simple acantholysis EB. In 1993, there are 3 cases described of EAS or EBS, one with acantholysis, but there are not a lot of histological description. A few years later, there was a publication of this keratosis with histological features. And what have I learned from this patient? Well, how to deal with a very severe simple EV in the neonatal presentation. We almost have given up on this patient. We thought that perhaps we would have to take specific measures because we thought she was not going to survive. We have found a diagnosis of 2 possibilities that were not the correct ones for the treatment of this patient, and the diagnosis of this patient. And this type of acantholysis is histological, histological feature that's not very well known. We need to have a better differential diagnosis of the entity with acantholysis of EB, simple EB with acantholysis in the neonatal area. And this is a very severe pathology. We were able to publish this experience to share our information. And what have I learned from this patient? This was at first during her first days of life, and this is the same patient years later. So we should never offer a definitive prognosis in the neonatal period, and we need to keep fighting for our patients, especially when we don't have a specific or correct diagnosis. So we have 2 subtypes of EB, one very mild that went away by itself, and one so severe that we thought the patient was going to die. And the first cases, it's important to have a good clinical history that will help us to reach a diagnosis even before we have the molecular genetic diagnostic. And the only problem here is the quality of life related to the pigmentation disorder, and there is no other problem. And from the severe simple EV, the optic microscopy will help us with the diagnosis. It's a cheap technique that will help us a lot. And acantholysis is something that we still don't know a lot about, but the prognostic value is very severe. This is the future for our hospital, and I invite you all to visit us in person whenever this is possible. Thank you. Thank you very much, Doctor. Excellent presentation. Very interesting cases, and the second was so difficult. We have some questions in the chat. You answer it during the presentation, but it relates to histopathology studies for these patients. Do you perform biopsies for all of the patients, even though genetic studies are so broadly available right now? Yes, it's due to our protocol in our hospital. We have to study all the patients with a biopsy for the antigenic mapping of the basal membrane. We all patients have it. And we all study, have genetic studies performed as well. Thank you. Thank you very much. Well, we have a lot of comments. Everybody saying hello and congratulations to you. It was a beautiful presentation. I don't know if there are any further questions from the panel for the doctor. Yes, I think there's one from Dr. Haas.
Yes, thank you for giving me the opportunity to comment on this very great presentation, and in particular, I want to comment on the last case. We learned during the time that the most severe skin fragility and blistering that we see at birth is in severe EBS. Of course, except of acantholytic EB, which is extremely rare. But patients with severe EBS can be extremely severe at birth, and doctors tend to think that it's Hurlitz or severe junctional EB, but actually we see intraepidermal blistering, and actually now we recognize the clinical picture and know that we have to fight for the life of these children. Thank you.
Muchas gracias, doctora Haas.
Thank you, Dr. Haas. It was a very interesting case. We learned a lot with this case and also with the others, because pigmentation, that's a real problem for patients, for their life. Very interesting cases. In our country, we had many patients with motif pigmentation. We had several families, and at the beginning they had other diagnoses, but the possibility of molecular diagnosis and the blisters and the hyperkeratosis and in the hands, that's very typical. After, once you see one, then we control and study the whole family. And we see a lot of cases in the province of Chaco. So we have several families. Well, very interesting. Also, we have one of these severe forms. Monica, maybe patients with motif pigmentation, we have many families, but not with the hotspot variants in exon 1, keratin 5, but with other variants in exon 9. It's a deletion, which is very rare, described only in Japan. Here, there are 15 families approximately, and it's the other way around compared to the patients that Asuncion presented, because there's no trunk sparing. The pigmentation can be because of the variants. And we have several generalized severe cases. We even have a patient with the same variants that Asuncion described. At the beginning, we thought it was a severe dystrophic, severe form of the disease. And then we saw the clinical picture. We did molecular testing, keratin 14 testing, and also it was very hard to accept this EB diagnosis because of the severity in the patient. We are used to trust, rely on the molecular testing, but the clinical presentation was so convincing. So now we are more sure that the baby is very small, so we haven't seen the outcome in time, but he will surely improve.